So this chapter is one of my favorites, just because of my clinical specialties. But bear in mind when we're going through this information, this is just your first introduction to it. We're going to talk lots more about it in other classes, so you don't have to know everything. You just have to get a general grasp of the information. The test questions for this material, basically chapter 8 on, they're all going to be case study type questions. It's going to tell you about patient and some different symptoms and then ask you a few questions about that. So I will set up some practice quizzes like that so you can get the idea of what they're like, but you don't have to be an expert right now. This is just an introduction. This chapter particularly divides into two neat sections. So I'm going to divide it into two sections. The first section is things that have fairly high incidence, fairly high prevalence, and you probably will see them in your career no matter what setting you work in. And then the second half is things that have lower prevalence, and you may or may not see them. And some of them you won't see. Even if you work in a specialty neurological clinic, you might see two or three of them in your whole career. So that's how I'm dividing it up. And the chapter sets it out neatly, so it makes it easy for me. So our learning objectives, we're going to talk about for each disease, we're going to talk about the etiology, signs and symptoms, what's different about this from other neurological disorders, the pathophysiology, what happens in the body, what happens to those poor little cells, and interventions, our treatment approaches in physical therapy. We will talk about some other treatments like medical treatments, but not in great detail. And the prognosis, what's the expected outcome? So we're going to talk in the first section, we're going to talk about ALS, Parkinson's disease, MS, and Alzheimer. And in the second section, we're going to talk about Huntington, Friedreich's ataxia, spinal muscular atrophy, and dystonia. So ALS, or amyotrophic lateral sclerosis, is probably something that you won't see a lot of. The prevalence is lower of this. It's a motor neuron disease, and in some countries, like in Britain, they call it motor neuron disease. They don't call it ALS. Or Lou Gehrig's disease, you'll sometimes hear because he's a famous American who had this disease. So 1 to 2 per 100,000 affected, so pretty low prevalence. 2 years median survival after diagnosis. And unfortunately, um, I know personally a few people that have died from ALS, and one of them was my aunt, my mom's oldest sister. So the typical age at diagnosis is 50s to 60s. The key features are that it affects both upper motor neurons, and the upper motor neurons are the ones where the cell bodies are in the cerebral cortex and they travel down to the spinal cord. The lower motor neurons, the cell bodies are in the spinal cord and they travel out to the muscles. So we'll talk way more about this in clinical neurology, but upper motor neuron and lower motor neuron symptoms will be a little bit different. And unfortunately, you get both with ALS. The key features of ALS include progressive weakness starting in one limb, eventually affecting all voluntary movement, including breathing. Chewing, swallowing, and speaking, those are all pretty important. 90% of cases have no known cause. It's called sporadic. They're idiopathic. I don't know what causes it. 10% are familial. The gene for ALS that account for that 10% was discovered in 2012. There was published in Nature, which is a British scientific journal, but there's still no cause and no treatment or no cure, basically. So what happens in the body is, for some reason, some unknown reason, the motor neurons in the spinal cord, brainstem, and brain start to die off. So they get demyelination and axonal swelling and atrophy in cerebral cortex areas where those motor neurons live. The clinical signs include lower motor neuron signs, which are weakness, fasciculations, which is muscle twitching, and muscle atrophy, and upper motor neuron signs, which include spasticity or positive Babinski reflex, which we'll talk about that in another class as well. It's just a test you can do. Hyperreflexia, which means your reflexes are um, more active when they're stimulated. And the typical progression is weakness. Some people say, oh, well, they don't realize they're getting weaker. They say, I'm just clumsy. It's a distal to proximal spread for weakness, loss of grasp, frequent tripping, and progressive involvement of all extremities. The medical management, there is a medication um, that may slow motor neuron destruction, muscle relaxants and antidepressants for symptoms, and non-invasive ventilation or tracheotomy if the diaphragm or C4 is affected. For physical therapy, the primary goal is to maintain functional abilities as long as possible and caregiver training. So the interventions we're going to do are strengthening, especially for trunk muscles for breathing, um, breathing exercises and conditioning, range of motion and mobility training, assistive devices, canes, crutches, walkers, wheelchairs. A lot of times people will come in periodically when they need an upgraded assistive device, a more supportive assistive device, and caregiver training, transfers in bed mobility and ADL. So it's really important to monitor for pressure injuries because when people start losing strength in their extremities, they can't unload the pressure. There's a risk of choking because of the swallowing issues and aspiration pneumonia. So some areas, if you live in a bigger metropolitan area, some areas have ALS clinics, which are multidisciplinary, where the person with ALS can go in once a month and sort of address any issues that they're having. I think that's a great idea, that multidisciplinary integrated approach. On to the next disease. Parkinson's disease is much more prevalent. The typical age at diagnosis is 60, and with 10 years average life expectancy beyond that. I have seen people with Parkinson's with more than that life expectancy after, but that's typical. That it tends to affect men more than women, but it does affect women. The big four motor symptoms, so it has motor and non-motor symptoms. But the big four motor symptoms are TRAP, so you can remember it, the acronym: tremor, rigidity, akinesia or bradykinesia, and postural instability. So the tremor with Parkinson's is a resting tremor, which typically starts unilaterally. So what we mean by resting tremor is, and it's usually in a hand, the when the hand is at rest, you get a tremor, and then when you go to do something, it stops. So the opposite of that is an action tremor, where you don't have anything at rest and you go to do something and you get the tremor. So action tremors tend to be more cerebellar in nature, people with cerebellar disorders, but you don't need to know that. With Parkinson's, it typically starts unilaterally. Rigidity, muscle stiffness, we call it a cogwheel rigidity, where it's a very ratcheted feeling of that rigidity. Um, Akinesia or bradykinesia is slowness of movement and difficulty initiating movement. And postural instability includes balance problems and a falls risk. The additional symptoms that people have, dysphagia and dysarthria, which affect the muscles of swallowing and the muscles of speech. So that stiffness, rigidity affects the muscles of swallowing and speech as well. And that's what causes those symptoms. Depression, memory loss, concentration difficulty, and masked facial expression. And those symptoms are more in the later stages of Parkinson's, but you will still start to see those. Not all people with Parkinson's have cognitive difficulties, but a large proportion of them do. Sometimes you'll work with someone who has early Parkinson's disease, and it's really hard to tell the different things. But the thing that people notice early symptoms and they sort of brush them off as, oh, I'm just getting older. And the tremor is usually the thing that sends people in. They go, I don't know, tremor, that doesn't seem like I'm getting older. And they go into the neurologist, probably get a referral to neurology. So the pathophysiology is the dopamine producing neurons in the substantia nigra, which is part of the basal ganglia system in the brain, start to die off. They die by apoptosis. So you get decreased dopamine levels, and that produces not just the motor symptoms, but it also produces the non-motor symptoms. The It's idiopathic. They don't know why the neurons start to die off. Your neurons probably start to die off. They're postulating that your neurons start to die off long before, years and years before you have symptoms. So it's very insidious, slow onset. The reason why it's not usually diagnosed until later in life is because the onset is so insidious. However, there is a version of Parkinson's called young onset Parkinson's where the degeneration happens faster. Lewy bodies are abnormal protein structures that build up in the cells that cause cell death in the substantia nigra, and the mechanism of that is unknown as well. Not everybody with Parkinson's has Lewy bodies. They show up on imaging, but not everybody has them. Risk factors include increased age, history of concussions, and really with the history of concussions, that has more to do with the motor symptoms that are classified as Parkinsonism. It's not classic dopamine level Parkinson's disease, but it's classified because it has the same motor effects. Exposure to cleaning chemicals or heavy metals, or sometimes industrial or agricultural chemicals. Protective factors, interestingly enough, smoking. That blows my mind because everything else, smoking is a risk factor. In this case, smoking would be a protective factor. Caffeine, and caffeine's obvious to me why it's a protective factor because caffeine produces a dopamine boost. That's one of the reasons we like it. And midlife physical activities are protective factors. So you can't get rid of Parkinson's, but with physical activity, you can slow the progression of the disease. And that is powerful. That's powerful. And it's something that the patient can do to affect their disease, which is great. So the clinical presentation, particularly later with later diagnoses, are shuffling gait. Sometimes they call it a festinating gait. Difficulty with turns because that axial rigidity um, axial rigidity is a symptom that you commonly see with the muscle rigidity. So you can't do turns with your trunk. So normally when we turn, we have some trunk motion. When you have axial rigidity, it's you kind of turn all in one piece. The term for it is en bloc turns, and it's pretty obvious. Once you know what to look for, you're like, whoa, that's an en bloc turn. Crouch posture, cathodic with hip and knee flexion. And again, that's in the later stages of the disease. Loss of trunk rotation and arm swing. Diminished arm swing often shows up early on. Sometimes, I've worked with people with Parkinson's for so long. Sometimes I'll work with somebody there in the clinic for something else, and I see the way they walk and the way they move and their arm swing, and I just think, wow, I know they haven't been diagnosed with Parkinson's yet, but I bet they have it. I say to myself because I'm not allowed to diagnose, but turns out a lot of times they do. That facial masked effect, flat affect, frozen facial muscles. It's always a joy to me when I'm working with someone with Parkinson's and I can break through that. It's awesome. So I love working with Parkinson's disease. It's one of my clinical specialties. So the treatment approach medically, you take dopamine replacement. Dopamine as by itself doesn't cross the blood-brain barrier, so you can take all the dopamine you want, and it's never going to get to your brain. But they give this precursor form that's called L-dopa or levodopa that can cross the blood-brain barrier, and then it gets converted to dopamine in the brain. Also, dopamine agonists, which increase dopamine production, and MAOB inhibitors, which prevent dopamine breakdown. Exercise has also been clinically shown or is shown in research to prevent the breakdown of dopamine. So exercise, yay, no side effects for that. Deep brain stimulation is an invasive procedure that can be done on some people when medications are ineffective. However, it doesn't affect the non-motor symptoms of Parkinson's, doesn't cure it. It can, for some people, improve the motor symptoms. I have worked with a lot of people with DBS, and it's not a cure, it's not a fix, but it can be helpful in some cases. Physical therapy interventions, timing is really important. People tend to have on-off cycles with their medication. If it's possible to schedule their PT appointments around their medication cycles, they can get more out of the sessions. However, if it's not possible and they have to come in during an off time, they still have to function in life during their off time. So you can work on basic functional mobility during off times because they have to do that at home. So I don't think it's a wasted PT visit if they're on an off time. It's just different focus. So early stage, we're working on range of motion, stretching, gait training with and without assistive devices, balance training, general endurance building, strengthening, endurance, cardio, all that stuff is great for Parkinson's. Large amplitude movements. Later stages, you are going to add breathing exercises, chest expansion exercises, more intensive mobility aids, and the person from Parkinson's can benefit from an interdisciplinary approach. The Parkinson's intervention that I'm certified in is called LSVT Big. It's a large amplitude movement program. There's also a speech version of it, which is called LSVT Loud. It's really great when people do one and then the other. And LSVT Loud focuses on voice amplitude, and LSVT Big focuses on movement amplitude, and they help each other. So one time I was working with a patient who was going to do both LSVT Big and LSVT Loud and had the evaluations for both. And one of the things that the speech therapist would do for the evaluation is they would test the volume of their voice. They have a decibel tester, you know. And so this person got evaluated for speech and then got set up with appointments for LSVT Big. It's 4 weeks, and then LSVT Loud. Well, after they did the decibel testing, and then after 4 weeks of LSVT Big, the speech therapist reassessed them, and their voice was louder without even specifically focusing on that. So the big movements helped everything. It was awesome. Great. It's great to work with a multidisciplinary team because you get to see those kind of improvements. So MS is another disease that you'll see in a lot of settings in PT because of the high prevalence. It's an autoimmune central nervous system disease, inflammation and demyelination throughout the brain, brainstem, and spinal cord. Risk factors: living north of the equator, or there's a MS band in Australia too, so also south of the equator. It's the latitude, it's how far away from the equator you are. Females tend to be more affected than males, even though certainly males can be affected. Northern European descent, so clearly there's a genetic component. Possible environmental factors besides the living north of the equator: viral infections, smoking, and stress. So the common first symptoms are visual disturbances, acuity, color vibrancy, eye movements. A lot of people that I've worked with who have MS have said their first visual disturbance, it was like they were looking through a screen. So I thought that was interesting. And a lot of times people say, well, visual disturbance, I don't know what that is. And then they wait until they get something else before they go in. Sensory abnormalities, so paresthesias, numbness, pain, tingling sensations, motor control problems, including peripheral muscles and bladder and bowel issues, and cognitive difficulties. So the key pathophysiological feature is there are lesions or plaques that are visible on radiographs throughout the central nervous system. So they used to have to do, there wasn't a definitive way to diagnose MS, but now they can do MRIs and CT scans and actually see the plaques and know that it's going on. Pretty interesting. So there are different courses of the disease. The most common, 80% of cases, is the relapsing remitting, where there are clear attacks and remissions and slow progression over time. The clinically isolated syndrome is a single episode of MS-like symptoms, and that's usually their initial presentation. And then when they have another relapse, that converts to relapsing or remitting. So 30 to 70% progress from a clinically isolated um, single episode to relapsing remitting. Um, Primary progressive is there's no clear remission periods. 10 to 20% of people show this. And you basically just have a steady decline from the onset. And secondary progressive is where relapsing remitting tends to convert to secondary progressive after 15 to 20 years, where you have fewer remissions or no remissions and then just a slow decline. And 60% of relapsing remitting patients convert to secondary progressive 15 to 20 years after diagnosis. So our role is to maintain muscular strength and mobility, range of motion exercises, gait training, and assistive device training. It's really important to consider fatigue, especially in warm weather. Not everybody, but a lot of people with MS tend to be very affected by warm weather. So if the weather's warm, they're weaker and have more symptoms. Alzheimer's is also very common. You'll see it in lots of different settings that you work in. Alzheimer's, the apostrophe S thing just kills me. The World Health Organization is taking the apostrophe S's off of every disease. So now you'll see Alzheimer, except spell check still except with the apostrophe S. Anyway, Alzheimer is the most common cause of dementia, and 50% of people over 85. That blows my mind. But there's average 10-year survival after diagnosis. 5 to 10% of Alzheimer is what's called the familial type. Onset is earlier in middle age, whatever that means, usually in the around the 50s, 60s. There have been dominant genes identified in the familial type. There's a rapid progression. If someone with Down syndrome lives to middle age, which they are living to middle age, people with Down syndrome are living to middle age way more often than they used to 20, 30 years ago. They can often have this type of Alzheimer's. Sporadic is 90 to 95% of cases, late onset, so into the big numbers, 80s and stuff. Unknown cause, age is the major risk factor. There's a genetic link that's been identified, but there's not a gene to protein to affect pathway that's been identified. Additional risk factors for sporadic AD include head injuries, depression, sleep deprivation, and hypertension. Doesn't that make you want to work on your sleep hygiene and keep your hypertension under control? Protective factors include, yay, regular physical exercise, mental stimulation, and a healthy diet. So every time the grocery store rearranges stuff and you can't find anything, just hope that they're protecting you from Alzheimer's. So enjoy that. The progression, typically the first sign that you see is loss of short-term memory. We all have, as we age, we all have some diminished memory, short-term memory. I heard one doctor say that if you forget where you parked your car, that's normal. If you forget that you have a car, that's worrying. So, we all have that, like, oh, you can't remember the name of that one artist that you used to listen to, or something like that. Usually, after the initial symptoms of short-term memory loss, you get some motor skill and language difficulties. People have trouble doing stuff they used to be able to do. Long-term memory loss and disorientation is kind of the next stage. And then eventually, unfortunately, it can progress to you're just unable to perform self-care and you can't really do anything, which is sad. There are changes in your brain, and it has not been established whether these are effects of Alzheimer's or causes of Alzheimer's. Probably effects from the latest research that I've read. I read a lot about Alzheimer's just because I'm interested in it. Anyway, neurofibrillary tangles inside of neurons and amyloid plaques outside of neurons. They used to think that was the cause, but now they're thinking it's an effect. There's brain deterioration, brain tissue deterioration in the hippocampus and the cerebral cortex. That's where your short-term memory lives in your hippocampus, and then long-term memory in your cerebral cortex. So that's not good. Enlarged ventricles and decreased brain mass. The areas that are most affected are the hippocampus, think memory, temporal lobe, think long-term memory, parietal lobe, think movement issues, frontal lobe, think decision making, executive function, and the cingulate gyrus, that is executive function, decision making. Death usually does not result from the Alzheimer itself. It results from infection because of pressure injuries or pneumonia or sepsis, icky things like that. We'll start talking about Huntington's in the next section.